I'd like to welcome you all to the Society of Skeletal Radiology Resident Education webinar. My name is Gunjan Malhotra, and I will be serving as the presenter for this session. It's my pleasure to introduce your speaker for this webinar, Dr. Philip Wong. Dr. Wong is a fellowship-trained musculoskeletal radiologist and division director of musculoskeletal imaging and interventions at Emory University. Dr. Wong completed his undergraduate degree in economics from Northwestern University. He then obtained his medical degree from the University of Florida College of Medicine in Gainesville, Florida, and completed his diagnostic radiology residency at Emory University, where he also completed his fellowship in musculoskeletal imaging and intervention. He has a particular interest in sports imaging and injuries, orthopedic oncology imaging, peripheral nerve imaging, as well as medical education. So I'd like to introduce Dr. Wong to give his presentation on the brachial plexus. Thank you, Dr. Wong.
Thanks, Dr. Malhotra, for that kind introduction, and thanks to the SSR and the Resident Education Club for inviting me to speak today. I was just gonna kind of wanted to introduce like residents and fellows and where else is joining in on kind of traumatic brachial plexus imaging. I know we all have nightmares from first year med school of the brachial plexus, and I kind of want to demystify it for everybody today. So I don't have any disclosures. We're going to review the advantages and disadvantages of different imaging modalities in the evaluation of brachial plexus injury, review imaging findings of normal and abnormal brachial plexus, and grading of nerve injuries, show some example cases with focus on MRI, and then a little bit of a review of the management and treatment options for traumatic plexus injuries. So the initial evaluation, obviously, we're very familiar with the four modalities, those being radiographs, ultrasound, CT, and in particular CT myelogram, and then MRI. This is the ACR appropriateness criteria table for the initial imaging for traumatic plexus. You can see at the top category would be MR brachial plexus, without and even with and without contrast as the kind of the number one option. So that's a lot of why the focus here today will be MRI, and that's what we do at our institution. So the advantages of brachial plexus MR, so it's the superior modality, as I just said. It has superior soft tissue contrast and still good and improving spatial resolution. You can localize and grade the severity of nerve injury, including deeper nerves. It's useful in evaluating end organ skeletal muscle denervation, and this can be prior to EMG. Identify other potential causes of plexopathy, including non-traumatic or compressive. Uh, a key one is also identifying preganglionic nerve root avulsions and identifying edema signal on the fluid sensitive sequence. And this is one of our one sequence here, the coronal stir that I nipped up, just to show you how nicely you can really look at the plexus and look at it, the symmetry or asymmetry of it on both sides, using the coronal stir MIP. Some of the disadvantages, of course, are it's time intensive, so that could lead to motion artifact, less dynamic capability in terms of being able to see changes with like arms up or arms down. Can be limited in patients who have metal or metallic devices like a spinal cord stimulator, pacers, ballistic fragments, which we see more and more commonly. I think particularly spinal cord stimulators are definitely getting kind of we're seeing a lot of patients with those, which poses a lot of issues with putting people on the magnet. And this is just an example of the susceptibility artifact from a reverse shoulder arthroplasty on the patient who had a brachial plexopathy after the arthroplasty. You can see kind of the susceptibility artifact afterwards on the MRI. So technical considerations, 3T is optimal, so that you can obtain a high resolution and image and high spatial resolution image. And we use a combination of high resolution two-dimensional and three-dimensional acquisitions. The 3D acquisitions allow us to do multiplanar curvilinear reconstructions and thin maximum intensity projection or MIPS, which I just showed you guys. And we use T1 weighted non-fat suppressed images and heavy T2 weighted fat suppressed images and vascular suppression techniques, which can include contrast enhanced vessel suppression techniques. And then coil selections, depending on what you have, you can use head and neck coils with flex coils, or some people use body coils. And here's an example of the kind of the head and neck coil with a flex coil on one of our magnets that we use. So what is our protocol? Um, we use a coronal T1 3D space here and without fat suppression. It's really nice to look at the anatomy, look at the bone structures, and look for muscle atrophy within the field of view. Um, the coronal stir 3D space is a fluid, it's fluid sensitive, um, and you can, manipulate it, do multiplanar reconstructions, do the MIPS. We also do a 2D sagittal stir of the affected side, high resolution 2D, T2 weighted 3D sequence of the cervical spine to look for preganglionic nerve root injury, axial stirs through the mid-arm and forearm to look for denervation changes along a nerve distribution. This is kind of what we call our myography study. And it's really important that we wait around 4 weeks after the initial injury before imaging with MRI. And I'll go into a little bit more detail later. But really, just doing it right after the injury, we get a lot of calls from neurosurgery to expedite this brachial plexus scan after a trauma. And we always have to tell them that it's going to have to wait like 4 weeks. And there's reasons for that that I'll go into. Ultrasound of the brachial plexus, which we can do. Some of the advantages would be it's non-invasive, obviously low cost, portable, still no radiation. You can do dynamic imaging. You can do guided procedures like nerve blocks, and you can also perform ultrasound on like claustrophobic patients or patients with contraindications to MRI. The problem is it's operator dependent and can still be time intensive. You cannot visualize the preganglionic nerve roots, and you may not be able to visualize the retroclavicular plexus or C8T1 nerve roots, and you may not be able to see that kind of fluid or edema within the nerve or within the muscles. And it is hard to see deep nerves with ultrasound. So I hope this image doesn't give everyone flashback, like negative flashbacks, but I do have this picture up when like I'm introducing Plexus to the residents or fellows and trying to remember the different segments of the plexus. But I do have this up while we're reading a brachial plexus MRI just to help kind of instill the anatomy when we're going over each case. So I'm just going to run a little bit over how I do like a normal plexus. And so this is the patient with a normal plexus. On the left here is a coronal stir that's mipped up. This line is kind of showing you where we are cutting on the sagittal view on the right side. So at the level of the roots, what I do first on the sagittal is I identify the first rib, and that nerve below it is going to be the T1 nerve root. Then you go above C8, C7, C6, and C5. And that's usually the anatomy of the plexus. You can get other variant anatomies, but this is typical what we see 5, 6, 7, 8, and T1. And normal nerves are slightly hyperintense to the adjacent scalene muscles. They should not be kind of the signal of like an adjacent vessel, for instance. That's too bright. And as we come a little bit more laterally here, we're now at the level of the upper trunk. So C5 and C6, also called the ventral rami, um, or the postganglionic nerve roots. The C5 and C6 will form the upper trunk. C7 continues as the middle trunk. C8 and T1 together form the lower trunk. And each of those trunks divide into anterior and posterior divisions. So you can see each division. And so kind of this is usually at the retroclavicular plexus. Excuse me. The UTA is the upper trunk anterior division. UTP is upper trunk posterior division. So anterior and posterior division, anterior posterior division of the middle trunk, and then the anterior and posterior division of the lower trunk. And so all three trunks divide. The As we move on forward, the anterior divisions from the upper and middle trunk form the lateral cord here. The anterior division from the lower trunk form the medial cord here. And then the posterior divisions of all three trunks form the posterior cord. And so this black void is that axillary artery. So this kind of looks like a paw print. So whenever you see this kind of like or bear print, you can think that you're at the level of the cord. So lateral cord, posterior cord, medial cord. Then we're going to move on to the branches. So the lateral cord will each cord will kind of give off two major branches. There are obviously smaller branch that arise from the plexus that can be more difficult to identify. I'm going to focus on the big terminal branches here. So the lateral cord will split into the muscocutaneous nerve and then send a contribution to form the median nerve. The medial cord will also send a contribution to the median nerve, and then the remainder branch is the ulnar nerve, and then posterior cord branches off into axillary and radial nerve. So these are the muscocutaneous, axillary, radial, ulnar, median nerve. And so when we're kind of going over traumatic plexus, and after we take a look at the nerves, and if we see something wrong, it's we're going to have to classify these nerve injuries. So Seaton and Sutherland kind of were these physicians that came up with nerve injuries. Seaton initially described nerve injuries in terms of neuropraxia, axonomesis, and neuromesis, which are in order of severity, where neuropraxia is disruption of the myelin sheath without Wallerian degeneration. And this is typically a transient or sensory dysfunction, which usually resolves on its own. And then axonomesis refers to axonal injury, resulting in, which does result in Wallerian degeneration. And neuromesis is the most severe injury, which is disruption of multiple layers of nerve with or without complete transection. Sunderland kind of went further into this and had 5 degrees of nerve injury, with the first degree corresponding to Seaton's neuropraxia, um, the second degree referring to more like axonal disruption. And then as you get into more of these other layers of the connective tissue of the nerve, and here's a cartoon of kind of how the nerves are structured morphologically. As you get to more like endoneural or perineural disruption, then you get higher grade of nerve injury, which go into the grade 3, 4, and 5, with 5 being the equivalent of neuromesis of complete nerve disruption. Grade 4 is neuroma incontinuity. And then McKinnon proposed a 6th degree where you can get a combination of different degrees of nerve injuries. So how do we kind of grade it on MRI? The beauty of like the Sunderland criteria is that it works really well with MRI. And so I know that this isn't the brachial plexus, but I'm using the sciatic nerve as an example to show you guys what we see with Sunderland nerve injury. So this is sciatic nerve here, and this is just abnormal nerve where you start to see first T2 hyperintense signal within the nerve fascicles. Here's the tibial nerve bundle, this common peroneal nerve bundle. You can see those little bright dots are abnormal nerve fascicles that are mildly T2 hyperintense compared to the common peroneal nerve bundle. And if there's no downstream muscle change, meaning there's no Wallerian degeneration, this is Sunderland grade 1 nerve injury. As we get to higher degrees of nerve injury, like Sunderland grade 2 or 3, you might see more fascicular nerve enlargement, like you do on this picture here compared to the one on the left. And then you would start to see some downstream muscle changes. And then this is a kind of an ultrasound correlate of a different patient, just showing you this kind of honeycomb appearance on ultrasound with the hypoechoic nerve fascicles, and then surrounded by that nice echogenic rim of fat. And then when you get to more grade 2, 3 nerve injuries, you get larger hypoechoic nerve fascicles, which are thickened and large and very different than this kind of honeycomb appearance here. And then with grade 4 or even 5 nerve injuries, you can see that you lose the architecture of the fascicles. They're disrupted. They're not this normal rounded kind of circular structures. And even out here, you can see that that epineurium might be disrupted right around here. So this is kind of the example of higher grade, maybe 4 or 5 nerve injuries with nerve disruption. And then this is a similar example of ultrasound where you really lose a lot of the fascicular architecture. Nerve is really enlarged, abnormal, and even the kind of the outer rim looks irregular and probably disrupted. And this is a abnormal course of a nerve secondary to a desmoid tumor in the popliteal fossa. This is the common peroneal nerve that's displaced, so we look for abnormal course of the nerve. Maybe it's tethered or displaced, depending on the what's going on. And then loss of the perineural fat plane on T1. T1 non-fat sets are great to also assess for not just muscle change, but muscle atrophy, but also kind of that normal perineural fat plane that you should see. And then secondary findings include denervation, muscle edema, and or atrophy. This is an example of this patient with a common peroneal nerve injury. We have just really extensive edema along the nerve distribution in the interlateral compartment of the lower leg. And then also in trauma, we have to include this images of the cervical spine. So we do a high resolution T2 weighted sequence of the cervical spine to look for the preganglionic nerve root injury. This is an example of a axial kind of a KISS sequence at the level C71. And here you don't see any nerve roots, and you see a large pseudomagnetic seal that's characteristic of a preganglionic nerve root avulsion. Um, and so MR neurography is really helpful actually in detecting preganglionic nerve root injuries, which can be detected by the presence of a pseudomeningocele or maybe discontinuity of the ventral or dorsal rootlets. Absence of a pseudomeningocele does not exclude preganglionic nerve root injury. So you're also looking at what the cord looks like. Is there any asymmetry? You're looking to really find those nerve roots and see if they're thickened or maybe they're smaller or just plain absent. And then you can look for blood products, cord edema, fluid collections that may also suggest preganglionic nerve root injury. Denervation changes or muscle edema in the paraspinal muscles and rhomboids are also suggestive of preganglionic nerve root injury. And typically, imaging of the plexus approximately 4 weeks after that initial injury allows for resolution of all the edema and hemorrhage within the injured region, which will help for actually identifying the nerves and seeing if their nerves are abnormal. And it allows for formation of pseudomeningocele so you can detect bringing preganglionic nerve root injuries a little bit easier. So there's multiple reasons why we wait 4 weeks after initial injury. So if a resident is insistent after someone who's just had a trauma on getting a plexus MRI, please just say no, let's wait 4 weeks. So then the question is CT myelogram versus MRI. I think traditionally CT myelogram has been the gold standard of choice for preganglionic brachial plexus injury. There's not a lot of data on CT myelo compared to MR, but MR has been shown to have a 79% diagnostic accuracy for detecting C5 to T1 nerve root avulsions with the sensitivity and specificity of up to 93 to and 72% respectively. Post-ganglionic lesions detected with similar sensitivity and specificity with CT myelogram is not able to assess that region. So big reason why MR is just really the go-to choice here is you can get really good kind of accuracy in detecting preganglionic nerve root injuries on MR while also being able to assess the postganglionic nerves. And MRI is non-invasive. There's no exposure to contrast or radiation as opposed to CT myelogram. If you have kind of like an inconclusive MR myelogram, then it's reasonable to kind of go for CT. But we usually stick to MR. You can see the comparison here with CT on the left, MR on the right, and you can see the arrows pointing to those ventral rootlets, which will eventually form the ventral primary rami or the nerve roots that form the brachial plexus. So going over some cases. So this is a 50-year-old female with continued left hand pain, numbness, and weakness after prior anterior shoulder dislocation. Arrow pointing to the left brachial plexus, kind of at the level of the glenohumeral joint. You can see a little bit of signal over here. And then these are just pointing to the different nerve branches of the median ulnar and radial nerve. And here's kind of the downstream myography. So how would you guys grade it? Sunderland grade? I'll give a minute for for people to perhaps give their answers. Yeah, so a lot of people are saying grade 2/3. Let me see if I can. And you guys are awesome. So this was a Sunderland grade 2 or 3. It can be challenging to tell the difference between Sunderland grade 2 or 3 nerve injuries. Kind of, it's that's why I tend to lump them together here because it's hard to tell a difference. But you can see that the median ulnar and radial nerves are thicker and brighter than the muscocutaneous and actor nerves here. But there's no real neuroma, like kind of nodular enlargement of the nerves. There's no transection, and there is downstream denervation change, which should differentiate grade 2 and 3 from grade 1. So this patient was treated conservatively and did demonstrate improvement over the course of 3 months. So this is a patient who came in, 22-year-old who developed left arm weakness and numbness after a gunshot wound. Um, Kind of this is our coronal brachial plexus, a little bit mipped up to really highlight the plexus. And then kind of the sagittal stir images here, give you a little bit chance to look at the images. And what do you guys think about Sunderland grade for this one? We're getting a little bit of grade 4. So they're in grade 5. So we all thought pretty higher grade nerve injury. And that was kind of my initial thought too. But this actually turned out to be some in grade 2 and 3. And if you kind of look back, you do see the blue arrow pointing to the area where the plexus starts to um, really get thickened and bright here. And this is kind of at the level of the divisions. And so here's the roots on here. These are normal. And the divisions are kind of highlighted by the circle. You can see how they are there. They're just thicker, brighter, and there's a lot of surrounding edema signal that kind of goes posteriorly where the ballistic tract is, highlighted by the red arrows. But there's no kind of really thickened neuroma like that's nodular, and there's no actual transection on the coronal stir. So this was actually still just a center lane grade 2 or 3. This patient was taken to the OR and confirmed with surgical exploration that this was really just a 2/3 nerve injury.
Dr. Wong, can I just stop you for one quick second?
Sure. Yeah.
Oh, I've noticed there's some questions in the chat. I've also
Okay.
noticed there's somebody that raised their hand. Can we have people put your questions in the Q&A and then We're actually gonna try and do a Q&A at the very end, if that works for everyone.
Oh, yeah, that's right.
So if you want to kind of migrate your questions to the Q&A, and then um, we'll try and avoid the hand raising until the end too, if that works. Thank you.
Thanks for that. Yeah, we'll keep going. I'll definitely get to your questions. And so this is another case, a 26-year-old with right arm pain and weakness following a stab injury. This is coronal on the left here, and then this is kind of like an oblique NPR, kind of showing the area of nerve injury. So what would you guys think for this grade? Yeah, awesome. So just to kind of, for the sake of time, this is perfect. Sunderland grade 4. So this is a nice example of a neuroma in continuity. Here's the brachial plexus, and then the arrow pointing to this kind of really nodular, thickened, and hyperintense area. Kind of if you, with the reformatted image, you can see how nodular it is here. But it's not completely transected. And then distal to this area of nodularity, there's this bracketed arrow showing the kind of the distal branches being hyperintense. So this was a good example of neuroma continuity. This is not the same patient, but I want to show you of a kind of intraoperative what it would look like. And this is the like a median nerve with the neuroma in continuity. You can see how similar it is compared to this MRI, for example. But just to kind of give you guys an idea of what this would look like in the OR. And this is a 30-year-old female with right arm and hand weakness after a motor vehicle crash. And so, how would you grade this one? Gonna give you a minute to look at it. Kind of focus your attention on this area here. Yeah, excuse me. So this is a Sunderland grade 5, where you have, discontinuity of C5 and C6. And we actually had a preganglionic root avulsion of C7. You can kind of see the pseudomymeningeal seal here. And C7 is also retracted from that preganglionic nerve root avulsion. So that's Sunderland grade 5. So a little bit about treatment for traumatic nerve injuries. I think it's important to understand the treatment so you can help your surgeon or the neurologist kind of figure out what to do. So management of traumatic brachial plexus injuries is dependent on multiple factors. The degree of nerve injury, so the Sunderland grade, the location, pre versus postganglionic, supraclavicular versus infraclavicular, and the mechanism. So the mechanism is important because for sharp open injuries like a sharp laceration, they might actually explore immediately because if it's a sharp, clean cut, then they may be able to repair it at that time. If the nerves are found to be crushed or ruptured, then they may tag it and re-explore in 3 to 4 weeks to allow for better identification of the nerve injury. For blunt and closed injuries like a motor vehicle crash, then the timing of surgery is a lot more controversial. So the potential for spontaneous nerve recovery is uncertain. Surgery is delayed at least 3 months to allow for potential spontaneous recovery, but waiting greater than 6 months may lead to kind of failure of reinnervation of the motor end plate, since it takes some time for the nerves to regenerate and get to their target muscle. So there's this kind of window that we play around with when we're trying to figure out when does the surgeon try to treat, and that timing is really important. So when there are a lot of times where patients come in with these traumatic nerve injuries, and they actually need like a stat MRI because they're getting into this potential window where it might be too long for them to get the surgery that they need. So early exploration and reconstruction in cases with pre-ganglionic nerve root injuries, They still might do early exploration and reconstruction, um, since spontaneous recovery is pretty unlikely. This is a kind of an intraoperative radiograph of a photograph of a plexus injury after a stab, and the C5 and C6 kind of nerve roots are here and they're transected, and so they actually did early exploration and repair. This is one of our kind of surgeons that we worked with. Um, what are the surgical options? So primary reconstruction is the initial management, which includes you can do direct end-to-end repair. Typically, if there's a gap of less than 2 centimeters, neurolysis is performed to release injured nerves from surrounding scar tissue from outside the nerve or from the within the nerve itself. So external neurolysis versus internal. Nerve grafting is performed when nerve gaps cannot be directly repaired. So that greater than 2 centimeters. Typical donor grafts are like the medial interbrachial cutaneous nerve in the forearm or the sural nerve in the leg. And then nerve transfer involves taking a functioning nerve to a non-functioning nerve. So you can typical kind of donor nerves that are functioning can be transposed to kind of the muscle that's intended that they want to work. So typical extraplexal donors include spinal accessory nerves, intercostal nerves, phrenic nerves, or the contralateral C7 nerve. So you might some folks might take the C7 nerve from the good side and wrap that around to go to the bad brachial plexus, which is pretty amazing. And then secondary reconstruction may be necessary to improve function, which includes tendon or muscle transfers. I think really what's important is saying that is knowing that the highest priority for functional restoration includes elbow flexion and shoulder abduction and external rotation. I really like this picture of the nerve that's cut on end here. And you can see these enlarged nerve fascicles. You can just imagine what that you can see that on MRI as well, which I showed you. And it's just really nice to look at this like picture and kind of get a grasp of what you should be expecting on the MRI and even the ultrasound. And then primary repair. So this is another surgeon that we worked with who showed us this picture of a patient who underwent nerve repair. And so they repair the nerves and then they put these like nerve tubes and fibrin glue around it to kind of protect the repair. And then this is an example of the nerve repair under ultrasound. And so here's a median nerve in the forearm in a different patient that underwent primary repair. You can kind of see the nerve here, and then these like hyperechoic foci, which correspond to the sutures within the epineurium of the nerve, and then the hypoechoic structures with the asterisks. That's kind of the nerve tubes and fibrin glue. So this is a longitudinal view of the nerve that's been repaired, and here's that nerve, the tubes around it. And then we have nerve grafts. So example of someone harvesting the medial interbrachial cutaneous nerve, and then the nerve is kind of folded upon itself multiple times to match the diameter of the nerve it's going into, which in this case was the transected median nerve here, and then they kind of coapt them together and then put the nerve tubes around and cover the sites of anastomosis. And then example of nerve transfers to help restore elbow flexion. And so they can take branches of like a median nerve, which previously innervated flexor carpi radialis, and transferred it to the biceps. You can do the same with the branch of the ulnar nerve and transfer it to brachialis to help restore elbow function, which is one of the main goals of these nerve transfer surgeries. So, in conclusion, just wanted to demystify the plexus a little bit, particularly for the trainees who might be a little bit hesitant to pick up a plexus MRI. Brachial plexopathy requires a multidisciplinary approach for diagnosis and management. You can use seating and Sutherland classification of nerve injuries to grade nerve injuries, and this can be correlated with MR neurography. And then MR and ultrasound neurography are really valuable tools alongside the clinical exam and electrodiagnostic findings to assist with preoperative planning and management of traumatic plexus abnormalities. Thank you.
Thank you, Dr. Wong, for your expertise, sharing your expertise and making this topic more accessible to everyone. So we'll move on to some questions. In the chat, we have a question about how many sequences are in your standard protocol at Emory?
Yeah, so for it will differ depending on like what the indication is, but for traumatic plexus, it's about um let's see, trying to think, five sequences. So it's the coronal T1 non-fat sat space, coronal stir 3 space, which are 3Ds, the sag stir 2D, and then the kind of a sagittal kiss of the cervical spine. And then the we actually sample parts of the mid humerus and forearm as like to look for downstream denervation changes. So I guess it would be six or seven sequences to do that traumatic plexus. That
Thank,
preganglionic nerve root avulsion is really important for the surgeons to know. So we have to include the KISS sequence.
thank you. Another question we have is, do you try and report the Sunderland grade in your dictation?
I actually do because that's what our surgeons prefer. So I try to do the best I can with silent grade 1 through 5. It can be like a spectrum, and if you're having trouble, I just describe it in that case. There is there is actually a injury reporting system, the NS RADS that from Chabra's team, Dr. Chabra's team at Southwestern, and they actually also kind of use something similar to Sunderland, but call it like in the setting of a nerve injury, I will use Sunderland. If it's like a nerve mass or a nerve or not like an injury to the nerve, I won't use Sunderland grading system.
Thank you. Do we have any other questions from our attendees? Okay, so I might have a couple saved. Let me see if I can find it. So, have you found ultrasound to be useful for evaluating patients with traumatic brachial plexopathy? And when do you kind of triage the patients to to ultrasound versus MRI?
Yeah, so I think if there are a lot of ballistic fragments or a lot of metal, for instance, that's remaining, or a lot of the patients that we scan out have plates that really will hinder us on MRI, then I'll do ultrasound in those cases, which actually is a lot more frequent now than it is before, um, just because of the amount of kind of metal that we're seeing in patients. So I do find it helpful. Then they'll end up getting like a CT myelogram or MR of the cervical spine if they don't have hardware in that region to look for the preganglionic nerve root injury. But I will try to image the plexus as best as I can for those patients, which is more and more frequent.
You
And
mentioned, here, go ahead.
oh, yeah, so when the surgeons, I've told basically the surgeon if they have a lot of like metal in the area, like a plate or in a ballistic injury, and there's still a lot of retained ballistic fragments, and they know to just order the ultrasound.
You mentioned that the ACR appropriateness criteria talks about with and without contrast being indicated. So when is contrast helpful for these brachial plexus?
Yeah, so some institutions, that's a good question. Some institutions use contrast enhanced MRI stir, and it helps suppress the vessels. Now, we don't really do that at our institution, but some do that, and it really does do a good job of suppressing the vessels and preventing you from getting like vessel contamination because it can be hard to tell. in certain cases, is that a vessel or is that a nerve that's coursing through? And if it's a nerve, then it's really bright and something's wrong. We don't really have that protocol set up yet, but I know that there are several institutions that do contrast enhanced MRI for traumatic plexus injuries.
Do you do whole body neurography, and is there a good resource for learning the nerve anatomy? E-anatomy can be overwhelming, is what one question is.
Um, E-anatomies are, I think we don't do whole body neurography. Uh, we kind of just really focus on whatever site is injured for patients, or even if patients have neurofibromatosis, we haven't really done full body full body protocols yet. Um, in terms of anatomy, I think there's a lot of actual like radiology papers that go over lower extremity, upper extremity. And I think those might be more helpful in kind of sharing like the kind of the course and the anatomy of those particular nerves. It's obviously overwhelming to go over every single nerve in the body, and it's okay to look things up when you're kind of find a new scan. So I think you just kind of take it one step at a time, and there are radiographics articles or AJR articles on each of these nerve injuries.
Do you have any tips for evaluating the post-operative repair or reconstruction in these brachial plexus patients?
Oh, post-operative repairs and reconstructions. I think um, if it's superficial, if it's a superficial nerve, um, I think ultrasound is going to be your best bet in terms of finding if the nerve fascicles or nerves are injured. I think that if you have a preoperative MRI or like a something to compare to, that would be the best way to kind of go about comparing. We don't get a lot of post-op plexus cases. I think if it doesn't, if something's going on where they have to re-image, I don't think there's just a lot for them to be able to do further, is kind of my thought. But it is challenging. I tend to favor kind of like any post-operative like tendon repair. Is it like full thickness and retracted? And kind of that's what I can tell as being like really bad. But if I don't have anything to compare to, then it's really hard to just tell if that nerve signal that's abnormal, was it there before or after? It's going to be hard to tell the difference.
And if there's a patient that has to wait 4 weeks, like you recommend, how often do they either have permanent nerve changes and healing changes without surgical intervention? And does surgery 4 weeks later actually help?
Yeah, so some of these patients spontaneously recover. So it depends on how traumatic the initial nerve injury is. Like, if it's like a grade 4 injury or grade 5 injury, Sunderland grade injury, those are usually not going to spontaneously recover. But it's hard to know in blunt injuries what it is um, initially. So they allow it to recover as much as possible. Then you image it and hope that all that hemorrhage and edema goes away so you can actually see the nerves and what they look like. And then they will do surgery. And surgery does help. I mean, you're gonna get different papers, but some will say that it's like 80% like of the patients that they do get better. It just depends on how bad the injury was initially, how long ago did it happen. But you do wait 4 weeks for a number of reasons after an acute trauma.
What are the common cases that an MRI of the brachial plexus is requested at your institution?
Um, I would say it's hard to say. I would if when we count Emory, it's about we did over 100 MRs of the brachial plexus last year at our level 1 trauma center, which is Grady Memorial Hospital. We probably did maybe 50. So it's just getting more and more common. I think a lot of that depends on your center. Is there a person who's going to be able to treat plexus injuries? Because if they do have someone who can treat it, then that person is going to get patients and they're going to order more plexus scans. And so we have a couple of folks who are um, one's a neurosurgeon, one's an orthopedic surgeon who are kind of subspecialized into doing brachial plexus kind of repairs or kind of nerve injuries.
Okay, thank you. And then one more that I see in the chat. Where did you get the training to perform the ultrasounds for brachial plexus?
Oh, kind of just my mentor who did it during fellowship, and then just kind of continue to learn as we kept scanning more and more patients. I think a lot of it is just you know scanning it yourself and keep it's honestly it's on the job learning.
That's true. You never stop learning.
Yeah.
Well, I apologize. I'm having some technical difficulties with my camera, but I think we're getting close to the end. And so I want to thank Dr. Wong for his lecture again. It was an incredible whirlwind and introduction to brachial plexus for people who are not familiar with how to interpret these and made it much more accessible. We have a survey link in the chat for people to fill out. So please do fill that out and let us know if you have any feedback. And with that, I will introduce I want to thank everyone for attending. Thank you for your interest in MSK radiology. We're excited to see so many people that are interested in MSK radiology at the resident level. Please do reach out to our programs when you're thinking about fellowship. I know both Emory and University of Michigan have great learning opportunities. So I'll put that little plug in. And thank you, Dr. Wong, again. Your presentation was
Thanks.
fantastic. And then I'll just say, I'll end it with the next session for the Resident Education Club webinar is going to be on January 14th. It's going to be approaches to congenital dysplasias, and it's going to be presented by Dr. Peter Fan. And with that, I want to thank everybody, and I hope you all have a good rest of your evening. And thank you to our Veritas team and IT folks for helping make this possible.